Dr. John Roshan, Professor and Head, Cardiac Electrophysiology Pacing, CMC Vellore. He is also the Program Director for the EP Fellowship at CMC. He is the recipient of many awards, including the prestigious A.V. Gandhi Gold Medal for Excellence in Cardiology. We heartily welcome you, sir. I would also like to extend our warm welcome to the moderators of the session, Dr. Rohan Gunawardena, Colombo, and Dr. J.S. Bhuvaneshwaran, Coimbatore, and the panelists for this session, Dr. Nandakumar, Coimbatore, and Dr. S. Ramakrishnan, Pollachi. Now over to Dr. John Roshan.
Thank you so much, Monisha, for that very kind introduction. I'm grateful to my good friend, Dr. Lawrence, for inviting me to the CHRS yet again. And it's a splendid academic feast that he arranges. With the permission of Dr. Bhuvaneshwaran sir and Dr. Rohan sir, I'll go ahead with my talk. Thank you. So I'll just start with my screen sharing. So I was just talking about anticoagulant therapy in atrial fibrillation and the need to balance the risk for stroke and the risk for bleeding. We are always sort of worried because when you see somebody and you want to anticoagulate him, you're also worried whether he will have a bleeding soon after. So the first case scenario, I just thought I'll present a couple of day-to-day case scenarios that we are faced with, just to sort of give us an idea as to how we go about making the decision. So there's this 52-year-old lady who had a prior myocardial infarction, and her blood pressure was 140/85. She presented with atrial fibrillation to the emergency department. Basically came in with palpitations and was found to be in AF. The rhythm reverted spontaneously to normal. Her echo showed mild left ventricular dysfunction, ejection fraction of 48%. Her left atrial size was normal and her thyroid functions were normal. She was sent home, and within the next 4 weeks, she had another episode of palpitations and was again documented to have atrial fibrillation. So what are we going to do about this patient in terms of stroke prevention? How do we go ahead? Now let's look at another case. This is a 67-year-old lady with paroxysmal atrial fibrillation. She's a diabetic, hypertensive, sleep apnea, chronic liver disease with varices, Child's B. Basically, she's got a non-alcoholic cirrhotic disease, and she's had a prior GI bleed. She's got esophageal varices. She's also had single vessel coronary artery disease and has had an angioplasty done. So what are we going to do in her situation? So to sort of get some idea about this, I thought we'll have a look at what background information we have on atrial fibrillation and stroke. As we know, atrial fibrillation is one of the notorious causes of stroke, and often stroke may be the presenting feature of atrial fibrillation. We also know that when you look at the various causes of stroke, atrial fibrillation usually results in much more severe ischemic strokes and TIAs when compared with other causes like carotid emboli. So the reason for this is not clear, but what people believe is often the thrombus, that it's a thromboembolic stroke and it comes out from the left atrial appendage, and hence the volume of the thrombus is much larger compared to that of a carotid embolus, which results in more severe ischemic strokes and TIAs. So this also results in greater disability and greater mortality. And the other interesting thing is that atrial fibrillation can also result in silent infarctions and TIAs. So you might have a patient who's had thromboembolic episodes but is blissfully ignorant of it. He just may not know that he actually has it. And later on in life, he presents to you with dementia. We also know from studies that patients with atrial fibrillation who have been on anticoagulation have strokes with smaller infarcts and lower mortality. So definitely anticoagulation helps, if not in anything else, at least in reducing the morbidity and mortality for the patient. We also know that a prior embolic event is one of the most potent risk factors. So all risk factors for strokes are not equal. Some are more significant than others. And so if somebody has had a prior embolic event, then you would give it a lot of importance in deciding on initiating oral anticoagulation. We also know that the first few weeks post CVA are the highest risk for a person having a recurrent stroke. So the other important thing which literature has now told us very clearly is that somebody who's got a CHA2DS2-VASc score of more than or equal to 2 clearly needs oral anticoagulation. So let's sort of go a little deeper into this. The first important thing is how do you evaluate somebody who's got atrial fibrillation? It's important for you to understand that the presence of atrial fibrillation does not mean that was the cause of the stroke. It does not necessarily mean, because there are a large number of people who have atrial fibrillation and not every one of them is dropping down to the stroke. So it's always good to rule out other causes as well when you have a patient with a stroke, even if you may find that he has atrial fibrillation. So the evaluation obviously comprises doing brain and neurovascular imaging, ECG, echo, and a transesophageal echo. Now, a transesophageal echo being normal does not mean you have ruled out atrial fibrillation as the cause of an embolic stroke, because residual thrombi need not always be present. Also, you often need to do a transesophageal echo prior to cardioverting the patient. Now, the key answer to this whole talk is basically individualizing the patient. So if that's one thing you want to take home, is that don't treat everybody the same way. You need to individualize the patient. You need to involve the patient in the decision-making process. You need to explain to the patient what the condition is, what the pros and the cons are, and make a joint decision along with the patient as to what he is comfortable with. So basically, you need to risk stratify the thromboembolic risk. You need to risk stratify the bleeding risk. And then finally, look at how you can get the maximum benefit with the least amount of complications, and based on that, sort of go ahead with initiating antithrombotic therapy. So what is the challenge? The challenge is basically that some of the risk factors that predispose somebody to a thromboembolic event are also the same risk factors which predisposes him to bleeding. Hypertension is one such common example. Hypertension is a risk factor for thromboembolic events. It's also a risk factor for bleeding. So that sort of makes it difficult to sort of separate one from the other. In other words, if somebody is a hypertensive, he's at a higher risk for a thromboembolic event, at the same time a higher risk for bleeding. Then we also look at how do you treat these people, and treating for thromboembolic episodes obviously increases the risk of bleeding. So that makes it again complex, because while you're trying to suppress one evil, you are going to eventually result in increasing the chance of another evil. And then when you look at stroke and bleeding, it's important to understand that they are on a spectrum of severity. And so just predicting the risk of stroke or the risk of bleeding does not necessarily convey or make sense to the patient. Now, what I'm trying to say is this, that a person could have had a stroke and had complete recovery. So also another person could have had a stroke and may have been reduced to a vegetative state. So you have this big spectrum. You are just looking at reducing the chance of stroke. But when you're talking about strokes, you have a big spectrum. You have minor strokes with complete recovery, and you have major strokes leaving the person with residual morbidity. Are you able to see? Can I move ahead? Are you seeing my slides?
You are fine, sir. Please.
Okay.
Visible, sir.
Thank you.
Go ahead.
So now looking at the tools to predict thromboembolic events. So obviously people have tried to categorize and look at the risk factors which predispose thromboembolic events, and so also try to look at the risk factors which predispose to bleeding. So there have been scoring systems that have been come upon, and the following are the various scoring systems that have been evolved over time, starting from simple things like looking at a CT scan and a cardiac MRI, where you look for showers of emboli or embolic events in the past, lacunar infarcts, all of which suggest that the person is at a high risk for thromboembolic events. In addition to that, there are other scoring patterns which include the ABC stroke score, the Framingham risk score, the CHA2DS2 score, and the CHA2DS2-VASc score. So of these scoring patterns, the CHA2DS2 score was the one that we were most familiar with and was the one that was extensively in vogue about 10 to 15 years ago. So when you look at that particular scoring pattern, it gives you 1 mark for congestive heart failure, 1 point for hypertension, 1 for age more than 75, 1 for diabetes, 1 and 2 points for a prior stroke or a TIA. Now on the right side panel, you can look at the adjusted stroke risk over here. And it's interesting to see that somebody with a CHADS2 score of 0 has a 1.9% adjusted stroke risk, which sort of was the drawback of the CHADS2 scoring. So it means that somebody who's got none of the risk factors on CHADS2 is still at a risk for stroke. So does that mean we should start him on oral anticoagulation? And when you're looking at a 1.9% adjusted stroke risk, and you compare it with other cardiovascular risk factors like dyslipidemia and other risk factors which predispose people to adverse cardiac events, and you look at the event rate, and you figure out that when you look at something like dyslipidemia and for which statin therapy is started, the adjusted stroke risk is quite similar, which means somebody at a risk for a stroke with 1.9% adjusted stroke risk should technically be initiated on some kind of prophylaxis to prevent him from having stroke. But paradoxically, you're saying his CHAD score is 0. So does that mean all people with CHAD score 0 also need oral anticoagulation? Or is it that some of them need and some of them don't? So that was sort of the issue with the CHADS2 scoring. On the contrary, when you looked at higher values in CHADS2 scoring, like the values of 4, 5, 6, it gave you clearly what adjusted stroke risks were, and those predictions were pretty accurate. So when it came to higher values on the CHADS2 score, the CHADS2 score performs well, but when you look at the lower value of 0 is where we have an issue. So what were the drawbacks? Primarily, some of the common stroke risk factors were not included in this. And the other funny thing being, a score of 0 means you still have a risk for stroke. So this obviously had to be improved upon. And so they came upon 3 additional risk factors, of which age, sex, and vascular disease were added. Now the thing about age is that age is a continuum. And they realized that you can't sort of just say above 75 is a risk. They figured out that above 65 is also a risk. And so they came up with this new criteria, which they incorporated into what's the CHADS-VAS scoring, which helped better differentiate the CHADS2 scores of 0 and 1. So again, in our daily practice, it's important for us to understand that these are all continuum risk factors. And so somebody of age 65 and somebody of age 74 are not necessarily at the same risk. Somebody at age 74 is definitely at a higher risk for a thromboembolic episode than somebody at age 65. Though the person at age 74 as well as the person at age 65 would still get 1 point as far as the CHADS-VAS scoring is concerned. So if you look at the CHADS-VAS scoring, it gives 1 point for congestive heart failure, 1 for hypertension, 2 points for age more than 75 as against what the CHADS2 scoring did. It gave 1 point for diabetes, 2 for stroke, TIA, and thromboembolic events. So this was better defined here by incorporating thromboembolic events as well into this particular criteria. And then they brought in this important 3 things where they said age 65 to 74, they gave it 1 point, females were given 1 point, and vascular disease. Now, it's important for you to understand that just being a female does not put you at risk. So you need to be a female more than 65 to classify as a risk. So just being a female does not account as a risk factor. And when you looked at vascular disease, they brought in 3 things, which included peripheral vascular disease, atherosclerotic plaques in the aorta, and prior MI. Now, prior MI basically is looking at something that can result, it refers to coronary artery disease, but it's also important for you to understand that coronary artery disease can also lead to ventricular dysfunction. And I'll come to that in a bit. So people obviously compared the CHADS2 scoring with CHADS-VAS scoring to see which was superior. And they looked at the CHADS-VAS scoring of all those people who were 0 points on CHADS2 score. So you take the CHADS2 score and you take people who score 0. That's the group that still had a 1.9% chance of a stroke. And when you looked at them and you classified them with the CHADS-VAS scoring, you found that some of those people who were CHADS2 0 were actually CHADS-VAS 3, whereas some others were CHADS-VAS 0. And now when you looked at the 1 year stroke and thromboembolic event rates, it gave you a much better spread, with 0.84 being the event rate when CHA2DS2-VASc was 0 and going up to as high as 3.2 when the CHA2DS2-VASc was 3. So clearly from this paper from Olson et al., it was quite clear that the CHA2DS2-VASc scoring helped us better discriminate the CHA2DS2 scoring, particularly when it came to the low values of 0, thereby helping to clearly determine who needs and who doesn't need anticoagulation. And if you look at this, when you look at the CHA2DS2-VASc criteria, you can see somebody with CHA2DS2-VASc 0 effectively has a 0 chance of a stroke, and as the numbers build up, your risk for a stroke builds up. So back in the day in 2014, there was this recommendation made in circulation which looked at CHA2DS2-VASc scoring and said if the score was 0,
Roshan, sir, sorry to interrupt, sir. Your slides are not moving, sir.
Oh, I'm sorry about that. Is it moving now?
No, not yet.
Okay, I'll just stop sharing and reshare.
Yeah, that will be better, sir.
So when you're looking at treatment recommendations back in the day in 2014, this paper published in circulation suggested that those with a CHA2DS2-VASc score of 0, you wouldn't do anything for them. Those with a scoring of 1, you would either not do anything, or you would give aspirin, or you would give oral anticoagulation based on discussions with the patient and the comfort zone. And if it was 2 or more, you give oral anticoagulation. Now, when a couple of things that we need to discuss, and first is the C in CHA2DS2 and CHA2DS2-VASc. The C stands for congestive cardiac failure. And obviously, when you look at that risk factor, you're thinking whether the patient has been admitted in cardiac failure, and based on that, you grade the patient with 1 point or don't grade it. But it's important to understand that the history of heart failure alone is not a consistent stroke risk factor. And what studies have actually shown thereafter are that systolic impairment of ventricular function, whether it is moderate or severe, is an independent risk factor. So that is something to be cognizant about, that even if somebody has not actually had admission for cardiac failure, if he's got systolic dysfunction, which is either moderate or severe, then you would definitely give him 1 point when you do his CHA2DS2 or CHA2DS2-VASc scoring. Now, when you look at those with CHA2DS2-VASc score of 1, so these will obviously be people who will be CHA2DS2-0, but they are a CHA2DS2-VASc of 1, which means they are at a pretty low risk for a stroke or a thromboembolic event. So now the discussion comes into whether to give aspirin or whether to give oral anticoagulation. And most people are comfortable with aspirin, surely because of the fact that it's a drug that has been around for much, much longer time. And there's this paranoia about initiating oral anticoagulation. And we were all grew up in the age when we used drugs like warfarin, which needed monitoring, which did not often stay in therapeutic range. And because of all these reasons, there was always a bias towards giving aspirin. But interestingly, we are having a large number of studies now. I've just quoted 3 of them down there, but there are plenty of studies which have looked at this and clearly say that oral anticoagulation is better than aspirin when it comes to stroke reduction and mortality. And more importantly, the benefit of oral anticoagulation increases with age. So quite contrary to, we often look at somebody and say, oh, he's 78 years old, and sort of shy away from giving an oral anticoagulant and are more comfortable giving aspirin. But surprisingly, the evidence is quite contrary. The evidence actually strongly supports the role for oral anticoagulation as age gets more. So these studies have all questioned the benefit of aspirin, because the benefit of aspirin decreases as age increases. Also, contrary to our misconception, the risk of hemorrhage and the rates of hemorrhage have been similar in those on aspirin as well as those on warfarin. So in fact, aspirin is just not only just that it's not safe, but it's also less effective when it comes to elderly people. And the current general opinion and consensus based on all the evidence we have is that aspirin is something that you may probably avoid for stroke prevention in AF, and it's wiser to go with oral anticoagulant drugs. Now, obviously, why are we worried about oral anticoagulant drugs? And that's because of bleeding. So then people started to look at how to predict bleeding, and they looked at the various scoring systems that can be evolved towards predicting bleeding. So there are a number of scorings here, which includes the ABC bleeding score, the bleeding risk index, the Atrial score, the HASBLED score, and the hemorrhage score was one of the very first ones to sort of come into being. If you look at the hemorrhage score, it looks at hepatic renal disease, ethanol abuse, malignancy, older age more than 75, rebleeding, reduced platelet counts or function, hypertension, anemia, genetic factors, risk of excessive falls, which may be sometimes due to a neuropsychiatric illness, and stroke. Now, when you look at these risk factors, there are some risk factors which are sort of unique, like the presence of malignancy, presence of genetic factors, and the risk of excessive falls. These factors are not there in the other scoring systems which are looking at bleeding risk. And it's important for us to keep these risk factors in the back of our mind, because there are some situations, like I said, every patient has to be individualized, and you may follow one particular scoring pattern, but it's wise to look at the other risk factors that may be there that are not part of your scoring pattern, but are definitely going to increase the chance of bleeding. The problem with the hemorrhaging score was that things like genetic factor and platelet function need special labs and special evaluation. They're not sort of bedside, which a doctor can sort of see in the OP and make a diagnosis as to what his bleeding risk is. So clearly they needed something that was more easy to use on the outpatient basis. The factors that I have put down in orange, like hypertension, age more than 75, and stroke, are factors that are also predisposing people to thromboembolic events. So like I said, the big problem is that the same factors that predispose somebody to thromboembolic events is also predisposing them to hemorrhagic events. So after time, obviously, people came up with the HASBLED scoring system, which was a lot more convenient to use on an outpatient basis. So it looked at the following clinical characteristics, namely hypertension, which got 1 point, abnormal renal and liver function. If both were present, you get 2 points, one for each. Presence of a stroke, presence of bleeding. Bleeding included having a predisposition to bleeding. So somebody who has esophageal varices but has not bled so far, but has got cirrhosis of esophageal varices, would score 1 point on that. Labile INRs, elderly people, and drugs or alcohol, which get 1 point each. The drugs that were considered include NSAIDs and antiplatelets. Alcohol was quantified as more than 8 units per week. When they looked at labile INRs, they were looking at the time spent in therapeutic range if it was less than 60%. And bleeding history included those who needed transfusions, those who had a drop in hemoglobin of more than 2 gram%, or even those who had anemia. Stroke included those with prior history of a stroke as well as lacunar infarcts on imaging. When you look at liver function, they were looking at bilirubin more than 2 times normal, or enzymes like OT, PT, or alk-phos being elevated more than thrice normal. And renal function, they looked at people on dialysis, transplant, and creat more than 2.26 milligrams per deciliter. Hypertension was defined as blood pressure more than 160 systolic. Now, just want to also add the fact that people on dialysis are always high risk for bleeds. Now, this has been something that has been looked at in several other studies, and it doesn't always come along with the other risk factors. So that's something to be wary of. And renal dysfunction is also a predisposing factor for thromboembolic events. So that again doesn't fit in with other thromboembolic scoring, but it's something to be cognizant of. So how does CHADS2 scoring, which was the original scoring before CHADS came into being, and HASBLED relate to each other? So there's a study which actually looked at 1,580 people with CHADS2 scoring of more than 1. And these people were started on oral anticoagulants. And among those with CHADS2 score more than 1 who were started on oral anticoagulants and had no major bleed, 34 of them, that is 2.2%, actually had HASBLED scores higher than their CHADS2 score. So of those who had no major bleeds, only a very small percentage of people had HASBLED scores higher than CHADS2 scores. On the contrary, when they looked at those who actually had major bleeds, so there were 33 who had major bleeds, and in that, 12% had HASBLED scores more than CHADS2 scores. So technically what this study sort of suggested was, if your HASBLED score is greater than your CHADS2 score, mind you, they're looking at CHADS2 and not CHADS-VASc score here, they felt that the risk of bleeding is high. So people have then looked at all these scoring systems that we've had, and I showed you a big list of scoring systems used for the thromboembolic events, as well as a big list of scoring systems used for the bleeding events. And they found that for the thromboembolic events, there were 3 scoring systems which were probably a cut above the rest. And of them, the CHADS-VASc score was probably the best. When it came to bleeding scores, the HASBLED score scored way better than all the other bleeding score indices. So it would make sense in our day-to-day practice to sort of look at the CHADS-VASc score for individuals and the HASBLED score for individuals, and also keep at the back of our mind the various other predisposing factors like presence of malignancy. Is there a genetic predisposition? Is there a patient on dialysis and renal dysfunction? Keep all these things in the back of your mind and add them in to sort of make your decision. So technically it's a balancing act. And clearly if somebody's got a CHADS2 score of more than 2, he needs oral anticoagulation. But what if the HASBLED is more than the CHADS2? Same way, if your CHADS2 is 1 and your HASBLED is more, then what do? Because your risk of bleeding outweighs it. So will you avoid oral anticoagulation or will you go ahead? So there's been some controversy on this, and if you look back at the literature, there are people who suggest to sort of avoid as well as there are people who don't avoid. And so let's sort of look into that. So what is the role of the HASBLED score? Now, most importantly, we should understand that the HASBLED score is not defined so that you exclude oral anticoagulation therapy. That is not the reason why that score was developed.
I'm extremely sorry for the interruption, sir. We are left with 5 minutes for the presentation.
Sure.
Thank you,
So
sir.
the HASBLED score was created for us to be able to identify bleeding risk factors and to correct the modifiable risk factors. So what are the risk factors that can be modified? And that includes blood pressure, which needs to be controlled, alcohol intake, which should be reduced. And you often have people taking NSAIDs for body aches and pains and orthopedic issues, which needs to be addressed and discontinued. So if we did these simple things, we would be able to modify the risk factors that predispose somebody to bleeding and continue them confidently on oral anticoagulation. Now, when you look at oral anticoagulation, we are always scared of oral anticoagulation because we think starting oral anticoagulation predisposes people to bleed. But if you look at those who had adverse events on oral anticoagulation, this paper looks at that and found that almost 50% of them were due to errors in medication, 30% were due to adverse drug reactions, and 70% of these adverse events were preventable. So it's not as bad as it happens to be, and the prime reason is because, there were issues that could have been prevented which were not prevented, and part of the reason is because warfarin was used big time as an oral anticoagulant, and warfarin has got its drawbacks, as you all know. Because those on warfarin, only a quarter of them achieve therapeutic INR. So every now and then you have people whose INR is not in the therapeutic range and they have an adverse event. So clearly we have enough and more studies now showing that the newer oral anticoagulants are superior irrespective of the CHADS-VASc score when it comes to treating patients with atrial fibrillation that is not rheumatic in etiology. So what are the options that you have in somebody who's got a very high HASBLED score as well as a high CHADS2 score? So some people think of giving dabigatran low dose as against dabigatran high dose, because dabigatran is one of those NOACs where we have a dosing of 110 BD as well as a dosing of 150 BD, which has both been evaluated. And there are trials which show that the 110 BD helps reduce the risk of major bleeds compared to the 150 BD. So that's one option. The other option to keep in mind is the left atrial appendage closure. And it's important to understand that the HASBLED score is a better tool than the CHADS-VASc score to predict the patient's prognosis post left atrial appendage closure. So there's actually a very nice study which shows that. And when your HASBLED score is above 3, it may make a case to consider left atrial appendage closure. And there is a trial which has got a limited follow-up of only 2 years, but it has actually shown that the risk of thromboembolic and bleeding episodes are similar when your HASBLED is more than 3 and you have done LA appendage closure. So that's something to keep at the back of your mind. The problem in our country is that a large number of patients are not going to be able to afford left atrial appendage closure. There are some things that are unaccounted for, one of which is hypothyroidism, which can cause acquired von Willebrand disease by lowering factor VIII levels and creating platelet dysfunction, predisposing people to a chance of bleed. Renal dysfunction figures in the bleeding scores but doesn't figure in the thromboembolic scores, but it can predispose to thromboembolism as well in patients on dialysis. So that's something to be wary of. So going back to our case scenario 1, in a 65-year-old lady with a prior MI, if you look at her CHADS2 score, it would be 0. But if you look at her CHADS-VAS score, it would be 3 because she's a female 65 years of age with ventricular dysfunction and she would need oral anticoagulation. So this is why the CHADS-VAS score scores better than the CHADS2 score. And looking at the case scenario 2, where it was a 52-year-old lady with paroxysmal atrial fibrillation, she had diabetes, hypertension, sleep apnea, CLD with esophageal varices, and coronary artery disease. So she has got a high CHADS-VAS score of 4. She had a HASBLED score of 3. Now this lady, we had a discussion with the family, explained the risks to them. Obviously, she's already had a bleed with those esophageal varices, and even after treatment, the hepatologists were really anxious about those varices. So we went ahead and put in a left atrial appendage device closure for her. But as you know, LA appendage closure is not equivalent to oral anticoagulation, because LA appendage closure is only taking care of the left atrial appendage. It doesn't take care of other sources of thromboembolic episodes. So what's the future? The future is basically the need for a score that takes into account both thromboembolic and bleeding risks, putting them together so that it makes it easier for us to make decisions. And it will be good if you have a score that can account for differences in severity of outcome. Like I said, a severe stroke and a mild stroke. So stroke can have a big spectrum. And it should be easy to implement. It shouldn't be something that requires lab tests and time-consuming genetic evaluation. And more importantly, biological age is more important than chronological age. So you can have a 75-year-old man who is as active as a 55-year-old man, and you can have the vice versa. So that's something else that these scoring patterns don't take into account. So in conclusion, it's important for us to individualize treatment. It's important for us to be cognizant of the fact that there is no good scoring available. We should factor in that systolic dysfunction is also a risk factor and not just congestive cardiac failure. So somebody who's got an LVEF of 40%, who is active, has never been hospitalized, is still contributes to 1 point in terms of risk. And it's also important to use your HASBLED scoring not to drive you into fear and shy away from oral anticoagulation, but more importantly, look at the risk factors and see what you can modify towards limiting his risk for a bleed. So with that, I'll end my talk, and thank you so much, chairpersons and the audience, for your kind listening.